ENCELTO, and Celto Revokinogene Teveretso Lui, an FDA-approved treatment that may be right for your patients. Visit incelto.com/ECP to learn more.
Welcome to the New Retina Radio Journal Club with VBS. My name is Nikki Kothari from Texas Retina Associates in Dallas. I'm joined today by Dr. Jesse Sengillo from Bascom Palmer.
Good evening. Thanks for having me.
And I'm also joined by Dr. Nicholas Farber from Southern Vitreoretinal Associates in Tallahassee.
Thanks, Nikki. Happy to be here.
Thank you both. And today we're going to be discussing an article titled Assessing Surgical Competency Among Fellows in Vitreoretinal Surgery, a survey of fellowship program directors and fellows. This was authored by Hassan et al., and it was published in Ophthalmology Retina in January of 2025. Dr. Sengillo, can you summarize this paper for us?
Sure, absolutely. So the main purpose of this study was to look at different vitreoretinal surgery fellowship programs and assess surgical competency amongst the fellows and essentially gain insight into their perspective on their own training and the program director's perspective on their training as well. So the methods that they used was a cross-sectional survey, and it was sent to 42 PDs, so program directors that responded, and 40 fellows that responded. This was a mix of academic and private institutions. And the main results that they found when asking questions about surgical competency was that PDs and fellows showed similar rankings for the importance of various teaching tools, the top three being direct observation of the fellow, number two being discussion between faculty and fellow on their surgical performance, and then lastly, looking at outcomes of the fellow surgical cases. They found that both fellows and program directors agreed that at graduation, there was a high level of comfort with various complex surgeries by the time of graduation. This included primary scleral buckle, proliferative vitreoretinopathy detachments, and then more advanced detachments like PDR and giant retinal tears. Of note, they did make mention that there was less comfort with pediatric retina and oncology. Both groups considered autonomy as a very important indicator of surgical competence. And lastly, there was an overall agreement on several aspects of a hypothetical national competence standard, which we'll discuss a little bit more in detail. And fellows, interestingly, responded to the survey saying they typically expect at least 300 vitrectomies before graduation, whereas program directors tended to be closer to about at least 200 vitrectomies. And their final conclusions essentially was that the study suggests that there's a need for a more systematic approach to assess surgical competency amongst VR fellows.
Thank you so much for that great summary, Dr. Sengillo. Dr. Farber, what do you think about their conclusion that we need something more uniform to assess surgical competency for fellowship? Do you agree with the findings of the study?
So I think this is a fascinating paper, and kudos to the authors. I think that, historically, we can think of vitreoretinal surgery training as apprenticeship. We are gaining confidence through doing and through watching our mentors. And a systematic approach assessing surgical competency is a great idea. And I think the how to do it is obviously, the details are the difficult part in this. I think it would be wonderful. Obviously, there is no standardized test that we took at the end of vitreoretinal fellowship. And while you could do a written test or you could send in videos, I think the development of a protocol is a great aspiration. I think it's a great idea. And getting all retina doctors to agree on what these competencies are and how to grade them is really half the battle, if not more. And so I do agree with their findings. I think it's a great idea and a great plan to have a systematic approach. I think the how is the difficult part.
Yeah, that's a great point. Do you find that the amount of respondents to the survey affected how you viewed the results of it? There were fewer than, I think they said 40 fellows out of hundreds during that time period that responded. Program directors had a pretty good response. Any thoughts on that?
I think it does shape our thoughts on this paper and the findings, but I think the trend probably stays. I think fellows are always going to feel like, I wish they wanted 300, and whereas the program directors wanted 200. Fellows always want more cases and more autonomy. I do think that's something the program directors and the fellows agreed on. I really thought the breakdown of university-based and private practice was interesting. It was 33 university-based program directors, 9 private, and 28 private academic fellows in 12. So you actually had a little bit of a higher representation from the fellows in private practice. And I think a lot of these private practices get great volume and a great diversity of cases. And I think that is always the question is, does every fellowship have the same access to the same things, or is there at least a baseline competency? In private practice, which I am in, are we doing more bread and butter, or are we doing just as complex as an academic center? And I think there are arguments both ways. So I think when we're extrapolating these findings to finding a systematic approach to grading fellows, I think these are all key points to consider. I do wish we could get more responses, but I think we can definitely take away trends from what we have.
Yeah, I think there's still so much to learn from this paper, especially just kind of reflecting on fellowship in general and variety in training. And we'll dive more into this, but I think now that we're all on the other side of training, now we look at fellows to kind of gauge, their competency in joining our practices or our universities. And so I think we're just as much invested in this and interested in this as anybody is, including fellows. Any final thoughts, Dr. Farber, before the break?
I think what you just said is a fascinating point, is that this is something we're all interested in, right? We are all looking to bring high quality fellows as our colleagues, whether that's into my practice, whether that, somebody I'm working with. We all want to know, that we all reach this minimum competency. And I think that how to do that is difficult, but I think it's a goal we can achieve. And so, I do think we should all be interested in these findings and applying them to ourselves.
Wonderful. Well, thank you so much. We're going to take a short break and we'll be back in a little bit for a more in-depth discussion.
Support for this podcast is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. Have you heard the latest news from Vabysmo? There's even more to see with 4 years of long-term data. Explore the RoanX open-label extension data at vabysmo-hcp.com. That's VABYSMO-hcp.com. Start first with Vabysmo.
Welcome back to the New Retina Radio Journal Club with VBS. Let's get into a longer discussion about the paper Dr. Sengillo summarized in the first half of the episode. Dr. Farber, how do you reflect back on your your fellowship, and now looking at competency? What were some things that your fellowship did that you thought helped to assure that you got to competency by the end of your 2 years?
So I was at the University of North Carolina in Chapel Hill, and I had the benefit, and I say benefit because every fellowship is different and everyone has strengths and weaknesses, but to me, it was a benefit to be the only fellow for 2 years at that time within a department of about 5 attendings. And so I was able to work very closely with my mentors. And so I think that having that very direct, very continuous conversations and relationship was beneficial to my learning. I could have immediate feedback. I wasn't going from one attending to the next, to the next, to the next, up to 10 to 20. It was the same ones that I could then grow and learn with and really come to understand their expectations and then how to meet those. We used surgical case conferences and medical case conferences. And I know we're specifically talking about surgery here, but reviewing cases, I think, is vital, but also having that immediate feedback and those relationships. I think that what the program directors and fellows in this study really highlighted is autonomy. And I think autonomy, being able to do a case by yourself and have good outcomes, is essentially what we're all going for by the end of fellowship. And so that graduated autonomy, that gaining your mentor's trust in able to perform every part of the case, is really what we're all aiming for, so we can do it ourselves. And that's a hard thing to grade. We all learn at different paces. We all develop at different rates. And so having a systematic approach to analyze that at the end, while great, I think it could be a difficult thing to establish.
Yeah, that's great. And it sounds like, one of the things in the paper that they discussed was direct observation was one of the things they valued the most. And it sounds like you got a lot of that in your training. Dr. Sengillo, can you reflect on your fellowship and some of the ways you feel like your program tried to assure surgical competency?
Yeah, of course. Yeah, I think overall it's kind of interesting in the career we're in. Ever since undergrad, we've been in such a structured learning environment at every stage of our career, undergrad, med school, residency. There's been all these check boxes and governing bodies that kind of regulate, these different stages to see if you're, competent enough to pass. And then fellowships are kind of a different structure. And so it's definitely, kind of an interesting thought. And I really like the paper kind of looking into this topic for that reason. At my program in particular, it's a larger program, 6 to 8 retina fellows at different stages of their training, and a lot of different faculty. So overall, I thought our faculty did a great job in giving feedback and creating one-on-one sessions to discuss our progress, and then having more formal sessions for things such as journal club and reviewing case videos and going through like M&M kind of style cases as well. So I thought those were all really helpful. And being that there was so many faculty, one of the things that I really liked too was that the schedule was such that you kind of worked with people in a longitudinal manner, so that you could kind of develop, and they could kind of train you at different stages of your fellowship. Overall, I think kind of when it comes to standardization and creating essentially standards for competency, it's interesting that it probably comes with a lot of headache. You see what our residency program directors had to go through in terms of communicating with the ACGME and ensuring that their program is meeting a certain standard. But it's probably on average an overall good thing to have a national standard and something that we all agree upon as a certain level of competency that is considered safe to go on to the next stage. And I really like Dr. Farber's definition of competency. Being able to do something safely alone is a really good definition. And I think with it too, when we talk about surgical competency, sometimes we also forget about the non-technical things, because I think a lot of the vast majority, at least the fellows I've worked with, all have the technical skill. But one of the things that's even more important, arguably, to develop is preoperative planning and making sure you're making the right decisions of when to go to the OR and what to do when you're in the OR. I think looking at those aspects of surgery as well would be important going forward.
I think it would even be interesting, Jesse, just to comment on that. If there were some minimum, let's say, competency or standardization at the end of the first year, can you do a primary vitrectomy? Can you do a peel? Because what we don't want is, we don't want our mentors teaching us to the test. We don't want them, they talk about this with standardized testing all the time, is that maybe it's limiting what you're actually learning because you're just focused on teaching to a test. And so maybe the timing of when are we actually doing this could be something to analyze, because I do think we are trusting in our mentors, and let's face it, all of our patients are trusting in our mentors, and all of our colleagues are trusting in our mentors to make sure we're competent before we leave. And we all have this shared understanding that we trust these people in these positions, that they know what they're looking for based on everything they've gone through and and all the teaching that they've had. So maybe having that first year competency, and then you can really, because I do think the training programs we have, and I'm very biased, but I think they're all great. I think they have positives and negatives, but I think that I've yet to, come across somebody and, we can't have a great conversation like this about the techniques, vitreoretinal surgery. And I think that's, a great thing for our field. But I think that maybe the how of doing this could be geared towards first year.
That's a great idea. And also that would probably cater to the fact that there's so many regional differences. There's places in the country that maybe do more buckles or more vitrectomies than other places, or see different pathology. And it would probably be really hard to standardize competency for that reason. So doing something where it's looking more at the first year is a great idea. Although I feel fortunate that none of us had to take like a written exam. We've had enough of those in our career.
So
Absolutely.
I'm grateful for that too. I think, you kind of highlighted on this, but, they've kind of defined competency by surgical volume in this study. Surgical complexity of cases is also important. How do you weigh number of cases versus the complexity of the cases if you were the one making the decision on competency and how to standardize that?
Yeah, no, I think that's a great point. So, when you're weighing complexity, how many TRDs, how many buccal fits, how many PVR cases are you going through, and how are you doing in those? I guess you could have somebody that's just a master at a Mac hole, but when it comes to those complex giant retinal tears, maybe they're getting hung up a little bit. So I think that is. I think the numbers bear themselves out. When we talk about those cases, how many have you done? There really is a learning curve. And when you do your first versus your fifth versus your 10th, there's a difference. And so I think that having minimum numbers is a great idea. I think that is at least the bare minimum as far as competency that we can all agree on.
When you guys now are on the other side of this and hiring somebody potentially to join your practice or join your university, do you assume that they're competent just based on completing fellowship? Or are you digging deeper and asking about somebody's surgical skills?
It's a great question. I guess the only position I've been in is interviewing residents for our fellowship, since I haven't been involved in hiring, obviously. But I think, you kind of look at the letters and there's usually something about surgical skill in there. And I think when you talk to the program directors or their attendings directly, sometimes you can kind of sort those things out. But it is similar to what we discussed with assessing our fellows' surgical competency. Although there is an ACGME standard for residents, sometimes it's a little bit hard to know what someone's surgical skill is coming into your program. And I think, fortunately, at least in my experience, from what I've seen, people do tend to come in at different skill levels, but tend to graduate at the same. And when they're in the program, they kind of over time it starts to become a little bit more homogenous in terms of where people are at. At least that's what I've observed so far. How about you, Dr. Farber?
I completely agree. I think that's a great point. When we extrapolate this from residency, somebody could do 300 cataracts, but they're all 2+ NS. There's no real zonular issue, and then when they are coming into your fellowship, you see, the difference. And I do think that everybody in our training programs is able to find their level and progress. I think that right now it's word of mouth. When we're hiring somebody, we absolutely talk to their mentors and we say, how are their hands? And I think that's one of the first things mentors will mention. Great personality, great colleague, great hands, and so I think that's something we already do, but it's word of mouth. It's not standardized. And would a basic proficiency assessment be valuable? I think so. I don't think we would all turn our nose up at it. I think that would at least say, okay, great. We don't have to worry about this one thing. They've done 5 TRDs, in the last month, and I can see a video or, whatever the assessment may be. So I do think that it would help in hiring, but I think at the end of the day, there are only so many vitreoretinal surgeons. We're a very close-knit group, and we talk a lot to each other, and we trust each other. And so I think it's a lot of talking. Just like not every person's going to be a great fit in every practice, not every graduating fellow is going to be a great fit, or some may need more time on some cases, more time on others, and that's okay. So having an assessment of that could be helpful.
Yeah, absolutely. I mean, I think at the end of the day, like you said, we're always going to dig a little deeper and talk to our colleagues and find out how good somebody is. But there's a lot of barriers to, like we've talked about, to be able to set a standard benchmark agreement among vitreoretinal surgeons, the time involved for the program directors. But our oculoplastics colleagues are doing it. And so it does beg the question that, maybe we should, and maybe we'd gain something out of it. Anything you guys would like to see specifically changed about how we approach surgical competency and fellowship?
I think that's a great point about our oculoplastics colleagues. They've already figured this out, and we can, I'm sure, learn from them. As far as what to change in fellowship, I think standardization of what is a primary vitrectomy, and I think we've worked on that and having some benchmarks. I think that that's excellent. And I think having, the ASRS or VBS, somebody can have, hey, let's all agree on these benchmarks. Let's all talk about this is what we think the minimum is, because I feel like that discussion just doesn't get had in our broader population. Maybe it's part of the PAT survey, or what do we all actually think? It's really hard to know. And I think just by setting those baselines, then we'd be able to move on to, okay, now that we have the baselines, what should our standards be?
Yeah, that's a really interesting point, is to kind of work backwards, find out what we think all as a collective group is competent, and then set benchmarks based on that. Love that idea. Well, thanks so much to you both, and thanks to the audience for listening to New Retina Radio Journal Club with VBS.